Welcome to Voices from the Field, the NAMA Next Gen podcast. I'm your host, Neil Nakkash. From Ebola treatment units in West Africa to the White House's COVID-19 response team, Dr. Bhadelia has seen firsthand how global health emergencies unfold. In this episode, I speak with her about her experiences on the front lines of infectious disease outbreaks and the future of pandemic preparedness. Dr. Bhadelia is the founding director of Boston University Center on Emerging Infectious Diseases, also known as CEID, and an associate professor at the Boston University School of Medicine. She's a board-certified infectious diseases physician who served as a senior policy advisor for the White House COVID-19 response team from 2022 to 2023. There, she coordinated interagency efforts for global vaccine donations from the U.S. She also served as the interim testing coordinator for the White House Mpox response team. In addition, she is the founding director and co-founder of the Biothreats Emergence, Analysis, and Communications Network, or BEACON, which is an open-source outbreak surveillance program. During the COVID-19 pandemic, she also served as a medical contributor for NBC and MSNBC. We're just incredibly honored to have a leader in infectious disease response with us today. So without further ado, here's my conversation with Dr. Bhadelia.
Thanks for having me, Neil.
So I just really wanted to first start us off by asking about your path. Just from reading about your bio, I've seen that you have a really unique path from working on the Ebola response in countries like Sierra Leone, to advising the White House on the global COVID-19 response. Could you just walk us through this your journey, this path?
Yeah, I guess my career is an example of you can't really plan your careers. You can only have a good sense of what you enjoy doing, what makes you feel good at the end of the day. So that's actually the advice I give everybody else who comes to me about what career path they should take. So I'm gonna go even more backwards than where you started.
Please do.
Uh, I'm an immigrant. I'm a 1.5er, which means, we moved here when I was a kid. We left India when I was 4 years old. My dad's a physician, and we moved into the Middle East and then in Sweden before settling in the US when I was 13. And so for me, I always knew that I wanted a career that had a global perspective. And medicine very early was something I had been introduced to, but I wanted something that was very much seeped in sort of the reflection of the world, the geopolitics, the culture, and infectious diseases does that better than anything else. It's a reflection of our how we moderate our own communities, what we think is important, and the nature around us, because they're not just human but also animal infections. So I actually knew by college that I wanted to go into infectious diseases, and I wanted to figure out a way to integrate that into policy, much like yourself. So I ended up applying. I worked for Oxfam America as a national campaign coordinator, working on raising awareness about economic development in resource limited settings for a year. Decided that had to be like the way that I approach my medical career. Went into medicine with a dual degree at the Fletcher School of Law and Diplomacy at Tufts, getting a background in health security and focusing specifically on how the HIV epidemic was becoming an AIDS epidemic, which means it was becoming an acute infectious diseases to a chronic disease, thank God, because of the antiretrovirals that we had, but it posed different type of challenges on healthcare systems. And then as I went through medical training, volunteered in multiple spaces for humanitarian response or medical response. But then in 2011, when I was finishing my infectious diseases fellowship at Columbia in New York, that's when H1N1 happened, which is if you remember, the influenza where everybody says, "Oh, it wasn't so bad. Why do we have to get so worked up?" It was pretty sizable, and had we not responded, I think it would have been a lot bigger. In New York City, it affected healthcare workers at overflowed hospitals, and it was sort of an insight into how acute disruptions like large infectious diseases outbreaks can affect not just people with those direct diseases, but
Mhm.
also on others. Did that realize I really wanted to focus, if I was going to do global work, I really wanted to focus specifically on emerging infectious diseases, because there is a level of uncertainty,
Mhm.
scientific uncertainty, and it requires best use now, best advice now, based on experience and current scientific knowledge, and that appealed to me. And so I actually emailed the director of our maximum containment laboratory here at BU, the NEDL, the National Emerging Infectious Diseases Lab, and I said, "Are you looking for someone to help you organize the human side of this? Like if there's a, God forbid, and
Mhm.
human infection in the maximum containment lab." And in fact, they were looking for somebody to set up their
Mhm.
medical response. So I started at BU in 2012, and I've been here, my goodness, I guess 15 years will be next year. And for a decade, I was the director of special pathogens unit and led the medical response, backing up the biosafety level 4 laboratory. So I helped design a 3-bed medical unit at our hospital, backing up and potentially preparing both the hospital healthcare workers as well as the city and state to potentially deal with either returning travelers with highly communicable
Mhm.
diseases or a potential infection. And because of that, got involved in the West African Ebola epidemic, where I was deployed in Sierra Leone, as you said, over 4 deployments in 2014 and 2015, working first with WHO and then with Partners in Health, providing direct care to Ebola patients, and then by the third or fourth deployment, also doing significant amount of infection control, healthcare worker training, and actually training Ebola survivors to go back and work
Mhm.
into ETUs. And in the aftermath of that, I ended up doing similar work in Uganda. Worked on a Department of Defense funded project called J-Medic, which was supported by the Ministry of Health as well in Uganda, which has become a center of excellence for clinical care for viral hemorrhagic fevers, because that triangle between Uganda, Rwanda, and DRC has a 33% chance of a filovirus case like every year. That's why you hear about the Marburg outbreaks and the Ebola outbreaks in that area. So I was the clinical lead for that program for about 5 years, and then COVID hit. And
Mhm.
here's another emerging infectious diseases that all of a sudden is on the scene, making us uncertain how to care for our patients, how to prepare our communities, how to communicate the uncertainty. So I helped, I was also both an advisor here to the state of Massachusetts and in terms of response, but also my own hospital, and was a frontline clinician during COVID response. And somehow got involved in media. I did for 2.5 years. I was a medical contributor for MSNBC, NBC, which was like a very interesting experience for me, going on national television talking about infectious diseases, because generally nobody's interested in hearing
Until they have to be interested, of
until they
course.
have to be.
Yeah.
Yeah, exactly. So it was also a learning experience, partly because, how do you communicate the best practice of how people should live their lives in the middle of so much uncertainty about what we know about a evolving pandemic.
Mhm.
And then as I was going through all that stuff, founded CEID, the Center on Emerging Infectious Diseases, which I still run, which just had its 5-year anniversary, or about to hit it next month.
Congratulations.
Thanks. And about a year and a half into it, I got tapped on the shoulder by Ashish Jha, who is the White House COVID coordinator, who asked me to come work under the Biden administration to help coordinate um, the interagency efforts around COVID-19 vaccine and medical countermeasure sharing globally. So my job was to coordinate with ministries of health, with international organizations, with our own agencies. President Biden had made a commitment that we'd get out 1 billion vaccines. So we actually ended up getting around 800 million out, and partly because by the time the vaccines were broadly available to resource limited settings, many of them had gone through 2 waves
Mhm.
of COVID, and there was a great amount of sort of COVID vaccine um, mis and disinformation. I think the countries themselves were struggling with, now the pandemic's receding, we're realizing TB, HIV, and all the other diseases we deal with every day are still emergencies, and measles, is coming back with a bang. Um, so did that for about a year. And when I was there, I was also the Mpox coordinator for the White House for testing. And then finally, when I returned, I helped found something called the Biothreats Emergence Analysis and Communications Network, Beacon, which is a surveillance platform at my center, which combines a network of human subject matter experts who are based out of my center, but based globally in 13 countries, as well as a large language model that's domain trained here that we use to sort of accelerate the amount of time that we have to reduce the amount of time we have to spend on reporting some of the infectious diseases that we report on. So I've been Been busy.
Hmm.
And that brings us to
Yeah.
today, which I would have told you maybe we'd had a lull after COVID-19 pandemic, but there's tons on the horizon and already affecting us. Climate sensitive diseases, vaccine preventable diseases, antimicrobial resistance, the threat of something synthetic that could be created right through synthetic biology that we don't even know what it could look like.
You're almost moving me right into my next question because I think, over these past almost 15 years now, you're saying that you've worked on several emerging and communicable diseases. And, you're someone who worked directly on the ground in Uganda and Sierra Leone, and particularly in Sierra Leone surrounding the Ebola epidemic. What are some lessons that you think we should have applied, but we just didn't, especially, 2019, 2020?
I think my number one, so Ebola epidemic changed me, not just as a physician, but also as a human being, because you intellectually know that life is unfair and that people die from avoidable deaths every single day. But it's very different to have like 50 to 60% of the people you're caring for die in your arms because you have hundreds of patients and not enough hands to help. And
Mhm.
you have a disease that's really hard to take care of, but partly is hard because there's not enough resources. The mortality in my ATUs was around 50 to 60%, and the mortality in returning responders who were sent back to the US was like less than 20%. And when we had a trial a few years later in Democratic Republic of Congo with targeted therapeutics of Ebola, the mortality actually could go down below 10% if people came early enough. So the number one lesson that I learned from that was, be careful what you call a high mortality disease, because the high mortality sometimes is just a result of the healthcare system in
Mm.
which the disease is presenting in. Like measles can have a high mortality right here versus somewhere else, a higher mortality, I should say. Um, I think the one of the major issues in the Ebola epidemic was diagnostic surveillance and early containment. And I have to say, so sometimes people would meet the case definition and they would be admitted to the Ebola treatment unit, but then have to wait days to get a potential diagnostic. Do you remember the beginning of COVID, how behind we
Mhm.
were in terms of just even realizing that it was in many, many different cities already, and we were there trying to follow a very narrow case definition. If they came from this country and this country and this country,
Mhm.
but we now have evidence that probably there was already a COVID in this country by beginning of January, if not earlier. And we just were missing it because of diagnostics. So I think that's a lesson that we still probably haven't learned because you can see potential threats on the horizon like H5N1 or avian influenza, highly pathogenic avian influenza, and even Mpox. We just reported, I wrote a report on this Mpox cluster of infections that's going on in Pakistan right now. Um,
Mhm.
7 infants, neonatal infants, infected with Mpox in 2 hospitals. But then also all these reports of strange lesions in kids and in like villages all around that area. But there's a lag in diagnostics, so we don't really know how big the cluster of infections is. And part of the reason is, again, lag in coordination and diagnostics. And here's why it matters, because where that cluster is happening, Larkana district, is where in 2019, 2020, there was a huge HIV epidemic that or outbreak that in the end was designated to transmission from the hospital, from a clinic where dirty needles were being used. And 70% of the 1,500 people who got infected were kids. And many of them are still living in that community. So it's like a double whammy,
Yeah.
of like injustice on injustice, if
Yeah.
you will. I think we still haven't learned the lesson, even after the epidemic, which is early diagnosis, quick response. I think we're getting better at it. We're getting better
Mhm.
at developing medical countermeasures. I think we're very bad at explaining why countermeasures are important and getting them to where they need to be after we've developed them, which is also what COVID showed, Ebola showed that, and then COVID showed that again.
Mm. I think when you're talking about us having weak diagnostic infrastructure, I guess lack of priorities there, it really leaves healthcare workers lost early in an outbreak. And you're someone who had to work through multiple outbreaks, as you were just talking about. Sometimes clinicians sort of have to work with limited data, unclear guidelines, and in those situations have to act before the evidence is fully there. So have you experienced that kind of tension? And, what do you do in that scenario?
Yeah, one of like a very exact thing that I can share is like during the Ebola epidemic, we were seeing a lot of patients who had central nervous system, like
Mhm,
encephalitis, meningitis type picture. And it wasn't widely accepted that this was a could be a common presentation, that Ebola could cross the blood-brain barrier, right, and cause the symptoms. There were like case reports in the past,
mhm,
but it wasn't really noted in the prior larger outbreaks. And we were seeing that, and it was kind of hard to figure out if what was happening to them was something concurrent, like a cerebral malaria or something, which can also present that way, or Ebola. And the tough part was in that setting, all you can do is like treat them for malaria because you have no diagnostics to be able to, or
mhm,
to safely do a lumbar puncture, right, to rule it out. Um, and and even if you did, like there was no treatment for Ebola, so it's really all supportive. Something similar, happened during COVID, where I think people were rushing to try to figure out what the best way to treat um, patients is, and they were looking for repurposed drugs to say, is there something already on the market that could work?
mhm,
And that's a noble thing to do. We want to do that. We want to look for effectiveness, but we probably um, want to do trials. We want to look to see, right? Or we want to look at the impact in a controlled setting. And I think physicians often or clinicians often reach for repurposed drugs because they're so desperate because they don't
mhm.
know what's the answer. How do I treat the patient in front of me so they don't die?
Yeah.
And I think we need a better infrastructure for repurposed treatments and how we study whether they're effective or not, rather than just throwing it onto a human's case and then complicating their case if there's side effects. So one example of that during COVID that didn't work out is ivermectin, which is, initially there was potential promise because there's some effectiveness in laboratory studies, but it became so widely used and accepted, even after there were trials done that showed really minimal to no impact, and then became part of the political landscape, right? Ivermectin became like call to
Mhm,
action of like, they're trying to get us to buy expensive Paxlovid and not ivermectin, which is cheap, even though there's no data. It's a complicated scenario when medical treatment gets like enmeshed in cultural in big settings in big emergencies like that. It's a very fascinating thing, and we actually just did a study that we just submitted for publication that showed that even after the COVID-19 pandemic, ivermectin use is just expanding. Like there have been almost 90 something bills introduced like since 2020 to now to get ivermectin access easier, like, either through the pharmacy or make it over the counter in some of the states in the US in particular.
Even if that's not actually rooted
Oh
in
yeah, and
evidence or
you
anything.
apparently it's used for everything under the sun,
Mhm.
like cancer, autism, like, just
The
it's
catch-all, I guess.
like, yeah, exactly. And it's quite interesting to me how it's evolved into this. It started off with this like real question of can we find something that could work, and studied and found that it doesn't work, but it's got like enmeshed in a lot of sort of, political stuff. And it's complicated because it's not just political, right, Neil? Because
Yeah.
I get people's like feeling of their healthcare is getting more and more expensive.
Yes.
Drugs are so expensive. So they're sitting there going like, am I being bamboozled if something's all over the counter? Why wouldn't I do this? Like why wouldn't I treat it? So I can understand where that feeling comes from, or feeling like the healthcare system is failing them and everything's expensive. But in this case, this actually causes more harm than help.
You caught me because I was just going to ask, how do you navigate that sort of political environment where, medication, especially as an ID doctor, like where medications are going to be considered, the catch-all treatment for something, some are going to be discounted. I guess as an ID doctor, how do you inform the public? How do you go about that?
Yeah, I mean, the care of a patient is usually within the confines of their own clinical care with their clinician, right? And so
Hmm.
with my own patients, is I tell them honestly what I think, right? I tell them what the side effects of potentially taking a drug that has no effect has. It can interact with other medications they're on. And other than that, in terms of on a societal level, I think it's just I think we just need more responsible legislators, because part of what's driving this is like legislators passing bills um,
Hmm.
driven by, I mean, it is a big business. There's somebody who's making money off of this, selling ivermectin, right?
Yeah. Yeah.
Uh, so I think whatever the interests are, we need more responsible legislators who don't pass bills that go counter to scientific evidence and medical evidence-based medicine.
My next question is a little bit, I mean, it's a little bit broad, but it really builds on this, which is that infectious diseases are clearly an issue of not only our domestic security, the security of us as individuals, but also global security. How has framing it that way? Because this is something that I've seen you focus on. How does it framing it that way alter perceptions or maybe shift people's priorities or actions, especially in our environment right now, where there doesn't seem to be a focus on global security, or at least from an infectious disease standpoint.
Yeah, it's a double-edged sword, right? If
Mhm.
you pose infectious diseases as a security concern, then it becomes potentially more prioritized in terms of funding and, elevation in terms of policy making. But at the same time, it takes away from a human rights-based approach, which is that every person
Yes.
needs the care, and it doesn't matter what the disease is. So the reason I frame it is because in specific, the kind of diseases I focus on are like the never events. They're pandemics, they're emerging infectious diseases that could affect public health or clinical response in a way that we don't anticipate. So regular systems wouldn't be able to take care of them. And
Mhm.
framing it that way shows that run-of-the-mill planning and systems won't take care of this, and additional investment is required, whether it be planning, training, diagnostic development, medical countermeasure development well before an outbreak happens, so this ready to go. And a perfect example of that again is like Marburg virus and Ebola virus, which after the West African Ebola epidemic, a lot of additional investments were made in organizations like the Coalition for Epidemic Preparedness Innovation,
Mhm.
CEPI, invested a lot on priority pathogen, vaccines in particular. And so now they have a Lassa fever candidate. They have, a bunch they're working on for viral hemorrhagic fevers. And the DoD and the US government and IH invested a lot more on some of the Ebola and Marburg therapeutics and monoclonal antibodies. And those were actually deployed in the recent Marburg and Ebola epidemics, recent Marburg and Ebola outbreaks in Rwanda, in Uganda, in DRC. A bunch of these were
Mhm.
deployed at variable speeds, and have had an impact. So um, I think that I think that we've gotten a bit better in terms of these responses. But
Mhm.
one of the things that I sort of struggle with the global health security framing is that people die every day from measles and
Mhm.
malaria. And chikungunya is not a killer, but chikungunya is like a climate sensitive disease which just had its own epidemic over the last year. And it affects people's economic productivity because in many cases you can have like results in 6 months, up to 6 months of like bone muscle pain, right?
Mhm.
So there are other diseases, tuberculosis, HIV, that people die of every single day. And so are they not security concerns, right? Just
Mhm.
because they are not a never event because they're happening all the time. So that's sort of the double-edged sword. One of the other reasons that I'm really concerned about the human rights approach versus the global security approach is that to catch the signal and the noise, to catch the next big thing, you actually need a human rights approach. So what do I mean by that?
Yeah.
50% of the world's population doesn't have access to primary care. If you don't have access to primary care, nobody will diagnose you with that big disease that just
Mhm.
spilled over from animals into humans, which means there might be a bigger cluster that happens eventually before it's caught. And that's actually what happened in West Africa. In Guinea, the primary case was in December 2013 of Ebola, and it took months before Ebola was actually diagnosed as a causative agent, and it already was in 3 countries in the area, right? So, perfect example of how primary care access is necessary to pick
Mhm.
up at the terminal end of surveillance anybody who might have an infection.
From a human rights perspective, we also have to think about stigma and, who is disproportionately impacted by a communicable disease. And I remember around the end of the West African Ebola epidemic, you gave a TED talk talking about how stigma is also an invisible killer. Not just that we don't actually invest in diagnostic infrastructure, but just stigma in itself. Do you think this has changed at all? Because, I've read some estimates that say as much as 94% of the American public contracted COVID-19. There sure was stigma at the beginning, but do you think the pandemic has, changed our reaction to stigmatizing infectious disease and who gets it?
No,
No.
I don't. I think people who have lived through the HIV pandemic and AIDS pandemic, right, know this so well, which is that um, I think humans and their fear of anything that is other sometimes
Hmm.
tend to conflate the infectious diseases with the human if they can other it, right? Because it kind of, I don't know if that's because it makes them feel safer, like it would never happen to me. It just happens there. It's not my kind of disease. And I feel that because so many people got COVID and because it was actually so politicized, it's kind of been made to be like no big deal. So everybody gets
Hmm.
it, like the flu. I that's why I don't think the underlying issue that I described in the TEDx talk about stigma has changed because people still feel the same way about Ebola. They if you
Hmm.
ask them what Ebola is, they say something that happens over there to people who don't look
Yeah.
like them, um, even though it could be imported, not it would never cause a big outbreak or pandemic like COVID did, because it's just a different type of disease. But I think it is a stigma is a function of who gets it and then
Hmm.
not just the disease itself,
Yeah.
right? And if it intersects with a population that already suffers from marginalization, then that's where stigma occurs because it makes it easier for the majority to then look at that person and go, oh, it's that kind of disease.
Hmm. We've been talking a lot about pandemics and epidemics, outbreaks, pandemics, and how uh, things have changed, how we've moved towards different models, just by investing in infrastructure where it needs to be. But I guess, God forbid this happens, but if another outbreak, pandemic were to emerge tomorrow, what do you think we would do differently? Like genuinely very differently? And where do you worry we'd fall into the same patterns? It seems that we're falling into the same patterns already, but I guess focusing really on what we would do differently.
Yeah, I think the advent of mRNA technology is like earth-shattering,
Hmm.
what the capacity of that is to potentially make us ready for the next threat. A potential, if you have the sense of where you need to attack a pathogen, like what epitope, what part, you could quickly generate vaccines within a couple of months, and it's
Hmm.
mRNA vaccines are also faster to manufacture. We'll still have the difficulty of trying to get them to where they need to be because
Hmm.
there's issues with cold chain, of course, the underlying like who gets it first, who gets it next. Um, but I think that we're going to be better at developing medical countermeasures. The problem is that we haven't learned our lessons, as you said, and we have divested here, at least here in the
Hmm.
U.S. from mRNA technology. I think we're also going to be better when it comes to potentially looking at what new technologies or other things could be deployed in settings. Like if you remember, everybody started using home tests for COVID. That was
Hmm.
like the first ever use of like home infectious diseases testing, right? I think there's a potential that that's going to roll out faster next time. Things that aren't going to change. I think we as humans have something called the normalcy bias, which is when something really bad happens, we want to make it not be real. And so
Hmm.
there's going to be delays at the beginning because of normalcy bias, where governments don't want to admit that it's actually happening or people don't. I think that unfortunately we will not have mastered issues related to equitable access and equity.
Hmm.
And I think we're going to still struggle with trust. And I think it's going to be worse now than it was before
Yeah.
because at least still coming out of the pandemic, there's a great amount of distrust in the public health and government responses to COVID-19.
And you've been doing a lot of work on this, just trying to move us away from sort of responding to pandemics when they actually happen or epidemics when they actually happen versus actually being prepared for us. Can you speak a little bit about that, just based on your, involvement in the Center on Emerging Infectious Diseases, Beacon, et cetera, all the great things that you're doing, so, basically.
Yeah. Well, I founded CEID partly. So CEID is a university-wide center at Boston University that works on public health, data science, and policy research related to emerging and infectious and emerging and re-emerging infectious diseases. It's interesting because every time somebody thinks readiness for infectious diseases, they go to vaccines, therapeutics, and treatments, which are very important. But I just told you the things that we're really bad at is everything else. It's the
Hmm.
communications, it's the health systems preparedness, it is the
Yes.
delivery. Those are the kind of things that SEED works on. And a couple of things that we've worked on, for example, I mentioned the DoD unit in Uganda, J Medic, which really was meant to generate an underlying capacity that improves the quality of care of patients with viral hemorrhagic fever so their mortality rate can decrease just because they're getting better supportive care. And then you could make it a platform on which to give them access to other therapeutics. Similarly, we did a training program in Liberia with a Fogarty grant where we wanted to help develop principal investigators out of Liberia.
Hmm.
It's a country that's been ravaged with civil war, a decade or so before the Ebola epidemic happened. And many of their intellectual capital, the folks who really were the leads, left the country. And with help of the NIH's Fogarty grant and with the University of Liberia, we help create a training program that has generated PhD candidates who go back and be principal investigators
Hmm.
around these issues. So there's the types of capacity strengthening work that we've done. And the last thing I want to mention is what I mentioned at the very beginning, which is Beacon, the Biothreats Emergence Analysis and Communications Network. So you can access it at beaconbio.org. It's a free disease surveillance platform. It's an event-based surveillance platform, which is that it complements formal reporting, but sometimes formal reporting can lag behind, right? Just
Hmm.
because of the data stuff. A lot of times there's data that's coming in from news stories, from on-the-ground accounts, from regional experts that you need to get out, even with like the caveats around like, hey, there's uncertainty around it. And by doing that, you move the needle to the left in terms of how quickly a response can be mounted. And
Hmm.
that's what the principle of Beacon is. And that's one way that we're working on decreasing the impact of infectious diseases, keeping cases from becoming clusters, clusters from becoming outbreaks, and outbreaks from becoming epidemics.
Well, we'll be sure to link Beacon down below, so check it out. And I really appreciate what you're talking about in terms of actually developing the infrastructure, the diagnostic infrastructure, reporting infrastructure, because that's something that we focus on a lot in this conversation. And it's promising to see that there are people who are moving us towards that. And it might be hard to imagine right now with our current environment, but if we were to bring you back on this podcast 10 years from now, say, what do you hope we would be different because of the work you're doing right now?
Well, I hope that we get rid of all the technical issues, right? Where, the science is already there in terms of being able to solve the promise of AI, to potentially discover new therapeutics, to potentially help us map the evolution of pathogens. I really hope we also make a U-turn on this
Hmm.
distrust around public health because I do think that's affecting individual care, individual health, but also population health. Measles is out back with a bang in this country. We're about to lose our elimination status, right? We have like I think over 2,000 cases or over 2,500 cases last year. And we already have 13. And it's what? It's April, the beginning of April. And whooping cough is back. I think in 2024 they had four times as much whooping cough as before. A lot of Coxemia and Neisseria meningitidis. There was an outbreak of meningitis, bacterial meningitis in UK because, again,
Hmm.
a combination of decrease in vaccinations, but also like the serotypes that are circulating. So vaccine preventable diseases, I hope they don't continue to go up in terms
Hmm.
of the threat that they pose, that we resolve that. But more than anything else, when I come back in 10 years, I really hope that the acceptance that every human life is equal, that
Hmm.
everybody deserves the same kind of access to, good access to care and timely access to care. And no matter where a death occurs, that is equally tragic. I hope that that is closer to humanity's psyche than where it is
Hmm.
right now.
Yeah, preach. I strongly agree with that. I really hope that this is something that is almost ingrained in us. We're taught to think this way, but it doesn't seem to happen in action. So one can hope that within as soon as possible, really, that we can move towards that.
Yeah.
I like to end us off always on a light note. We're talking about heavy things. So, before we wrap up, what are some books, shows, or, other forms of media that you'd recommend to our audience? Besides Beacon, of course, that'll be in the bio below.
Yeah. This is not meant to be self-serving, but it feels like it is. So there's a Katie Dowdy is this young writer illustrator who was a School of Public Health student at BU, I know many years ago, 2021, when she reached out to me and she said she was doing this illustrated novel about the end of the world and all the existential crises that we face. And so I
Hmm.
interviewed with her and we've kept in touch over time. And her book just came out. It's called How to Survive the End of the World. And
Hmm.
it is a beautifully illustrated book that just talks about existential crises, particularly for the young adult population, but really it's like amusing for everybody and informational for everybody. Goes through nuclear crisis, goes through environmental degradation, goes through pandemic risk. And so there's a section on it on the pandemic risk, and I'm a little illustrated figure in her book, which is why
Hmm.
I'm saying it feels. But I found that I just got a copy of it yesterday, and I've been like pouring through it because I'm learning so much about some of the other things that are going on in the world that I wasn't even aware of. So definitely check out Katie Dowdy's How to Survive a Pandemic. I think going back to basics, the things that I a lot of times assign to students if I'm teaching a class on emerging infectious diseases. One is Spillover by David Quammen, an old book that really goes into this interconnection between changes in nature and spillover into humans. A really wonderful book to read if you just want to get a narrative sense of like what we're talking about here in terms of
Hmm.
evolving sort of book. And Too late for when you will air this, but because I feel like wonder and scientific achievement is, we need to celebrate that.
Hmm.
Artemis is doing its circle around the moon today in about
Hmm.
15 minutes. So it will be on Netflix, but I say catch that because even though it's not an infectious diseases thing, it shows you when we put our minds to it what humans can do from a scientific achievement perspective.
Definitely, definitely. I'll check out all those things. And I have it. My brother messaged me. He's like, don't forget to miss it. You're gonna see Aramis like, circling the moon. He's someone who's really big in the aerospace. So
Yeah, I'm big in
yeah,
astronomy as well.
yeah. So but I'm definitely gonna check out the book by Katie Dowdy because I myself have been reading a lot of these books that really focus on existentialism. In recent times, Fahrenheit 451 is one that I read in high school, but I just had to come back to during this current moment.
Yeah.
A few months ago, I read The Plague by Camus, and
Oh, yeah.
that one I was like, this just rings on so many levels. So we definitely will check it out.
I feel like unfortunately all of Margaret Atwood's books are becoming reality, so I didn't want to
Hmm.
recommend it because it causes anxiety. It causes me anxiety to think back to them. The Mad Adam series or the Handmaid's
Hmm.
Tale, all of them, the environmental degradation, the destruction of rights for women. It's too much.
You know, the purpose of this question is always to end us off on like a lighthearted note,
Sorry,
but
we made it all
I
depressing.
know,
Go back
but
and watch the
this
Artemis. Yeah.
this happens so much. This happens so much because I think it's very real for the books, shows, and other forms of media that we're interested in to be directly related to the work that we do or are interested in observing, and so I just really appreciate the candor and the recommendations.
Yeah, thanks for having me,
Yeah,
Neil. Thanks for
yeah.
going through all this depressing stuff about infectious
No,
diseases.
no, no. Thank you so much. There's a lot of hope. There's a lot of work that's being done. So I really appreciate you highlighting the things that we need to do and the things that we are doing. So thank you so much for joining us, Dr. Bhadelia.
Thanks for having me.
Thanks for listening to Voices from the Field, the NAMA Next Gen podcast. If you enjoyed this episode, please make sure to follow us on Instagram, Spotify, Apple Podcasts, and YouTube to stay updated on our upcoming episodes. We'll catch you next time on Voices from the Field.